Good afternoon. I'm really delighted to welcome you to the second event of UTSC's 2021 Global and International Health Week. Let me begin by acknowledging that wherever we are located across this continent and beyond, our session takes place on stolen Indigenous land, and we recognize the continuities and strengths of the Indigenous peoples of these lands. Since we're meeting on Zoom, headquartered in San Jose, California, we also acknowledge the territory of the Muwekma Ohlone tribal nation. We're deeply indebted to the Muwekma Ohlone for the lands and waters they steward and that support the people and technologies that carry our sound, images, and words across vast distances. This acknowledgement also covers every link in the chain of production, including the enormous harms wrought on tens of thousands of child laborers in the DRC who extract the cobalt used in our devices. Now, each year, the Center for Critical Development Studies and the students in my course, IDSC 11, organize this Global and International Health Week, typically staged in the meeting place, part of our Scarborough campus. This year, our theme is Pandemic Perspectives, and we're thrilled to go digital and to have partnered with the Knowledge Equity Forum and the wonderful Maggie Huang and her team. It's a special honor to welcome our own alum, Mandekh Hussein, who will now be introduced formally by my colleague, Leslie Chan.
Hi, thank you, Anna Emanuel. My name is Leslie Chan. I'm a fellow colleague of Professor Byrne in the Center for Critical Development Studies at the UTSC campus. And we have a long-running IDS co-op program that is really in this almost 40 years old now. And Mandekh graduated, I just remember, 6 years ago. But Mandekh was in my first year class. I remember her because she was always asking questions. And she was also in in the final year, I remember her always asking questions as well. So she's still asking a lot of questions, which is great. And that's one of the reasons she's here as well. So anyway, I'm pleased that the Knowledge Equity Lab is able to co-host this event. And I'm also glad that Mandekh has agreed to be affiliated with our lab, which is a fairly new initiative that we started last year. It's really just both a physical and a virtual space for us to bring together students and community members who would like to work together to think about community challenges and how to co-develop research and learning experiences that would benefit both the communities and our students at the same time. And so we have a number of activities at the Knowledge Equity Lab, and I'm going to plug this podcast because we have just rolled out this episode today on the issue of health and knowledge equity. And Professor James Tuwini from University of Makerere in Uganda, who's editor of this African Health Science Journal, is open access. This year is the 20th anniversary, and it's been a pleasure working with him over these 2 decades to promote local journal, local health equity issues through local research. And so if you have a chance, please listen to the podcast. You'll be both surprised, stunned, by some of the revelations that Professor Tuwini shared, but also important lessons to learn about knowledge equity and health equity from his perspective. So without further ado, I really like to welcome Mandekh and welcome you for bringing so many of your colleagues from your side of the pond to take part in this conversation. So I won't spend more time in introduction because you'll tell people who you are, but just again to welcome you back to our program and to continue to have connections with us. And thank you.
Hi everyone, my name is Mandekh Hussein and it's an honor to be here with you today. As Leslie and Emmanuel said, I'm an alumni of the International Development Studies Co-op program. I'm currently a lecturer at Brunel University in the BASC Global Challenges program, where I focus on equipping students with the practical skills and the critical skills to address global challenges using transdisciplinary approaches. I'm also a primary care workforce consultant focused on supporting, equipping primary care staff with the skills to practice person-centered care and address issues of health inequality through collaborative means. I'm here today to speak with you on an issue very near and dear to my heart, trust and in health inequities in primary care. I'll first start off with some debates about how health inequities can be conceptualized, measured, and monitored, and from there delve into debates surrounding issues of health inequalities, and more specifically health inequities. I hope then to be able to get to a point where we can have a conversation about the role of trust, both in terms of access, information, and embedding within primary care, and some examples using some work that I've been doing recently with colleagues in Hammersmith and Fulham in London. So why this conversation? Health inequalities are ultimately about differences in people's health outcomes and people's health statuses, and I'll delve into the definition in just a moment. But the reality is it's something that impacts our day-to-day lives as a wider society, and for some people it hits closer to home. It delves into the conversations of postcode lottery about realities of healthcare experiences, about decision-making and opportunities that fundamentally impact the quality of life of individuals. And so this narrative is woven into sort of wider discussions of systemic inequalities and social injustices that requires a firm reflection on the issues of power, the issues of trust, and the wider issues of justice. But some key bits first. When I say health inequalities, I'm generally referring to sort of the differences in in the health of individuals or groups, sort of any measurable aspect of health, whether that is that in any measurable element of individuals' health, quality of health, and health experiences, and sort of what isn't included is that moral judgment component, and that's important to realize, whether it's, and not looking at it from a perspective of whether it's fair or just. In contrast, however, when I'm discussing health inequities, and a lot of the work that I do focuses on embedding it in the context of health inequities, on a personal level, is I'm focusing on health disparities. It's a type of health inequality that denotes a sort of unjust difference in health. And it can be seen when health differences are preventable and are unnecessary, and that structures or systems that may be allow them to persist in a way that is fundamentally unjust. In this sense, sort of health inequalities are systemic differences in the health that could be avoidable through reasonable means. In general, this might include experiences of injustice based on race or religion, that race, religion, sexuality, physical mobility, anything like that, socioeconomic experiences that reflect sort of the unfair distribution of health risks and resources as well. I guess a way of being able to describe it is that health inequalities is perhaps like just a general sort of descriptions of something unequal across the system, and inequity has that element of moral judgment, and I think that's always been the tricky element when having these conversations at system level, of whether or not there's an agreement that there's a moral judgment to even be had in the first place. And so by definition, health inequalities as a whole, but more specifically health inequities, go against the principle of social justice because there's an element of avoidability. They don't occur by chance or by happenstance. These are socially determined by circumstances that could be one, avoided, but are also like way beyond the control of many individuals. And so they disadvantage people at a fundamental level and limit their chances not only to lead a quality of life that is beneficial to them and their community and their families, but live longer and healthier lives. And there's been substantial work done across the UK, so across the country, in having these critical, not just having these critical conversations, but doing work to fundamentally get to the root of addressing them. And one great way that's being done is through the Deep End project, which I'll mention later on this evening. So when conceptualizing healthcare inequalities, there's an idea that health inequalities are caused by social inequalities rather than perhaps these risk factors. And this has become something that's well accepted across society. And so policy and research has shown us time and time again that there needs to be this multi-sectoral, transdisciplinary approach that goes beyond looking at it from an individualized ill health or medicalized perspective exclusively, but really focusing health interventions that also address the underlying social factors. And this is outlined in the Marmot Review into Health Inequalities in England in February of 2010. And this review proposed a sort of evidence-based strategy to address the social determinants of health and the conditions that people born, grow, live, work, and age within that can then lead to health inequalities. And it's a phenomenal read if you haven't had the chance to do so. But really, this evidence-based strategy to address health determinants, the social determinants of health, frames it in a way that discusses the complex interactions of housing, of income, of education, of social isolation, disability that affect one's social and economic status and also can impact their health outcomes and experiences of health inequalities and engagement, not just with the system, but in the wider process as well. But also that a lot of these experiences of health inequalities are fundamentally preventable, as there is as it requires a sort of like social justice component that looks at it from an economic perspective, so the economic case, but also as well looking at it from its perspective of how does this these health inequalities then permeate into wider social challenges that are experienced by individuals in a day-to-day life. And then the key is that action then is not going to remain within the domain of the medicalized sphere, whether it's primary care, acute, or community, but that the social determinants of health is what needs to be addressed in a holistic manner, so education, occupation, income, time, community, in order to be able to ensure that the health outcomes of individual are at the best position possible. So the documentation presented by the Marmot report, or the facts are presented by the Marmot report, are quite useful in the sense that it does align quite a bit with what policy should be moving towards in terms of looking at health inequality from a sort of like social perspective or social circumstances perspective, and utilizing harnessing policy and engaging in services and creating interventions that prioritize the prevention of these inequalities across systems, and shifting away from sort of these tick box activities in terms of like fixed quantitative enumeration of like numbering of experiences of risk to perhaps more proximate behavioral and medical risk factors, looking at whether or not in which way, poverty will impact the quality of life of individual, and looking at that as a measurement. But there also needs to be a way to operate that critically reviews the sort of upstream and downstream efforts. So upstream, talking about those sort of like interventions and strategies that look at the fundamental social and economic structures in order to decrease barriers to sort of support individuals to like lead healthy lives, and downstream focusing on that like equitable access to care and services to mitigate the sort of negative impacts of disadvantage on health. The key in all of this is that as human beings, we're complex and there's intersectionality in all elements of our experiences and work that we do. And it's key then that in order to address this wicked problem, we need to be able to find solutions that fundamentally do so as well. So let me move myself down a bit. So the barriers to tackling the causes of health inequities. I'm going to go back to that sort of like more narrow definition that I mentioned earlier. So although most health inequity researchers or practitioners agree that social inequalities underpin health inequalities, there's a sort of like debate about how to address it. And there's sort of conflict about what is even a health intervention, or is health inequalities intervention, in the sense that it might be perhaps one that is more targeted on geographical areas that are deemed as more deprived. And this is contrary, though, to some evidence that many people who live in poverty don't live along these like exclusive geographical boundaries, and we can find them in multiple places. And there's forms of inequalities that exist across social gradients, but this emphasis on neighborhoods drifts perhaps towards more so that individualized, rather than the sort of structural actions that entrench and implicate the problems within society, and perhaps amplify concerning narratives, if not managed correctly, or if not addressed or framed correctly, that it's an issue of poor lifestyles or lack of assets, rather than these wider societal patterns. But part of the issue about framing comes from a model that is quite rigid in its operation. And I'm reading into primary care right now. There's some practical barriers that emerge when tackling health inequities in its own right. And one comes from the fact that while there is a strong appreciation and understanding of social determinants of health and the consequences of them on health inequalities, the sort of time given even to make decisions influence whether or not health inequities are engaged. And an example of this is the time of clinical appointments, the sort of pressures already existing within general practice to be able to afford times to adequately and justly provide space to patients to be able to describe their concerns, but also for GPs to feel confident, or nurses or those within general practice settings to feel confident in addressing these challenges in a satisfactory manner. And in some cases, there's additional concerns, and like frequent reports of GPs who feel that there is a sense of complexity across the system as well. The challenge rooted in changing systems, about referrals, about feeling confident enough, both on in terms of their own knowledge, in terms of available resources, but also the sense of like comfort in addressing health inequalities. And this is a barrier, and I'll talk about solutions in a moment, but these are spaces for innovation, and great work actually has been done by the Deep End project, as I mentioned earlier, across the UK, and here in Hammersmith and Fulham, work done by Dr. Chad Hockey in terms of addressing this as well, and creating the space for networking as a key mechanism of increasing confidence, but also capabilities of addressing health inequalities at the local level, and the sense of relationship building, but also increased awareness allows individuals to have that level of confidence to be able to address health inequities. But when that isn't something that is entrenched within the learning environment, or something that isn't entrenched into day-to-day practice, or perhaps isn't even framed while addressing health inequalities, obviously, and framed within the wider work done across primary care, is not actively presented in a way that allows individuals to have the scope to address these in a tangible manner that reflects the needs of their community. It's quite hard to practice this on a day-to-day basis. Also as well, policy reforms may have that added layer of challenges. So the move to the sort of financial incentivization scheme of QOF, so quality outcomes framework, which is a pay for performance scheme isn't specifically designed to reduce health inequities or inequalities in its wider sense in any case. And so there's a sort of need to do this or need to do that, and there's quite a distraction about how you're able to see patients as well in terms of the relationships had with them, the relationships formed with them, if space is not provided to be able to address the underlying concerns or the underlying influencing factors, social determinants that then result in the need for individuals coming into primary care. It's not, I think that I have an absolute appreciation for the pressures that are existing within primary care. One of it is a sense of that moral desire to support the community and address the day-to-day needs of community members and the health needs of individuals and the wider community, but simultaneously doing so with 10-minute appointments, simultaneously doing so with system pressures, simultaneously doing this through disjointed and difficult to navigate services, reduced workforce numbers, create these specialized roles as well. And while there's individuals with complex forms of health inequities do experience these sort of buckets of obstacles in varying degrees and varying times, and perhaps the use of MDTs and multidisciplinary teams to create means of addressing these barriers or means of tackling health inequities. There's still the fundamental sense that this requires individual motivation, engagement, and then action on all sides to be able to do so, but ensuring that there's a wider system that supports and facilitating this as well. So in order to fundamentally address it, there's a three-phase approach that I use, not just for in framing how health inequities look like in my local area, but in the work that we do with community-based organizations, is sort of action, framing it in three different stages. So one is looking at it from action that can mitigate health consequences and of social inequality. That includes sort of the targeting of the health and social care perspective, ones that prevent social inequalities and their impact on health outcomes, and then the last on actions that undo policies and processes that cause social inequalities. And there are time and places where different actors are able to engage, but being widely aware that there's not one superhero that can perhaps address all of this, but there's a requirement that the assets of all stakeholders passionate about this cause are required in order to widely address this wicked problem of health inequalities across systems. Just to take a moment to flip for a second. And so we've been talking about health inequalities in its wider perspective, but if we bring it down to the practical day-to-day basis, there are multiple factors or experiences or elements that make it difficult for individuals to access primary care in the first place, and whether that is language barriers in the sense of having difficulty in being able to articulate and communicate their concerns or their needs at that particular moment in time, even with the use of a translator, the preference against using translators or telephone translation services, cultural barriers in terms of senses of perception of others, and we'll talk about that in the example that I give in terms of childhood immunizations later on. Forms of digital exclusion, which has become a growing concern given the current pandemic that we're in right now. Service access challenges, just navigating systems, even on the best of days, changes of services requirement, the sense of self-sufficiency, know how to be able to move from place to place and primary care had always been seen as a sort of hub of the community. It still is a hub of the community in many cases, but the challenge is the workforce available to be able to support individuals in navigating those spaces, given the increase in patient numbers across many of the practice. And in some cases, it's not the case, and in other cases there are, particularly with the introduction of new roles, such as social prescribing link workers, and that are able to have those relationships with patients in order to improve their experiences with primary care, but also enhance the relationship that they have with wider healthcare experiences, and by circumstance address issues of health inequities. But there's also the one that always I hear the most is, and I see the most, is the 10-minute appointments. In an effort to be efficient, are we creating increased spaces where individuals it's not just an issue of accessing, i.e. making the appointments, but being able to access and harness these appointments in a way that allows for meaningful engagement, where individuals feel satisfied at the end of the appointment that they've been able to get their concerns or medical needs met by the clinician opposite of them. There's just a last note is even something as simple as like registering for a practice was often quite difficult for many, particularly those with no fixed abode who had been told that you can't register to practice. And part of that is being addressed through increased awareness, both for the wider general public, for the wider public in terms of their ability to just register for practice, at a practice, to be a patient at a practice, but also on the side of receptionists that you don't actually need to show proof of address to register for a practice. And the barriers to GP registration are likely to impact the most vulnerable groups in any case who, due to sort of this like incorrect insistence that they need to have documentation, are slipped through the cracks. And we fortify that sort of sense of like distrust in the system or othering of groups of people. But with all of that said, is that the friction that emerges with 10-minute appointment, siloed working, with decreased workforce numbers in some cases, is a space for innovation. I believe it's a space for cultivating locally driven transformation by incredibly passionate individuals across the system who utilize various tools, digital, tactical, practical, that address the challenges faced by others, whether that's language barriers, digital literacy, appointment access, to include others, and also actively work in addressing sort of elements of that mitigate component of the individual experience that I mentioned earlier when it comes to health inequities. And so PCNs, for example, primary care networks, are expected to deliver this sort of like service specification across systems, across areas such as like improving cancer diagnosis. But there's sort of like this like loftier goal that they are meant to integrate local and healthcare systems into the wider community and local authorities as well, but like in a way that allows for there to be improvement in population health and reduce inequalities. And this is that last element that I mentioned is perhaps why there was such a great buy-in into the ideas of primary care networks as a whole. And but one of the biggest tension that emerged from this is like, how can a PCN be of the neighborhood, like of the collective, but also at the same time be part of a wider system? And this tension has become more and more evident over the last several months, in the sense that yes, while great relationships can be formed at system level, there seems to be this dichotomy between alliance to the system and alliance to the community that doesn't have to be this or that. It doesn't have to be an othering process, but rather the challenge associated with access to resources, access to time, alignment with views is quite challenging when the fundamental definition of health inequalities, or the framing of these inequalities, whether they're inequities or inequalities, it causes contention across all areas of the system. But there's great work being done at local levels that I really want to highlight. So that, for example, there is videos by Healthy in Your Own Skin in Hounslow that have done webinars on YouTube, not just about healthcare during the pandemic, but that were accessible to the wider community consumption in Hounslow in Northwest London, but talked about things like what temporary work and other in like employment in its wider sense that created innovation, in the sense of like, these are the needs of the community. How can we utilize these conversations to address mental health and well-being? Similarly, in Hammersmith and Fulham, the use of technology to address language barriers and empower individuals to be able to have the resources to effectively communicate their concerns and their needs during healthcare appointment settings. These sort of spaces for friction allow for those who are radical within the system to challenge norms and challenge the status quo in order to center conversations of inequity and inequality and holistically into the day-to-day practice of work. And this takes a lot of work, and complete kudos to everyone who's doing that. Because there is mandates from other spaces, there's contracts that need to be fulfilled, time that needs to be allocated to all of this. But all of this, and against the challenge in all of this, is being able to center the ability for systems to actively engage requires that element of trust. Requires that element of trust, not just amongst the system itself, but trust by the community and individuals who all of this at the end of the day is meant to be for. Is how do we move away from a top-down approach of practice to one that empowers the wider community, but also elevates the platform in which they have rightfully been trying to engage in or facilitate, and flipping the way in which we look at even the table of conversation. Is this a matter, should this be a platform that like an invitation in, or should it be like, let's knock down doors and knock down spaces so the system understands what the neighborhood, what the community has been speaking about, has been talking about in order to address these issues of issues surrounding social inequities, social injustices, and wider social determinants of health. So the sort of like element of trust in action is what I'd like to speak about right now. Trust formation is, I think, the key in addressing health inequities in a sort of multi-professional, transdisciplinary model, in a way that is sustainable, and a way that goes to mitigate, prevent, and undo policies and practices and outcomes that result in health inequities and health inequalities as a whole. It's sort of the bedrock of activities that are existent, and frequently barriers to healthcare are rooted in degrees of mistrust in services, of people in their roles, as a result of these experienced traumas, but also narrated traumas. So my work with Hammersmith and Fulham Council, local authority, and more specifically with like health team or wider team as a whole, or colleagues in public health, was with regards to addressing these challenges of trust formation, but more specifically issues that emerged during the pandemic. Previously, I'd always done sort of like loose coordination with community organizations, or through training of staff groups to feel that that they're equipped with sort of dismantling forms of everyday injustice and actively cultivate forms of environments that are welcoming for challenging discussions, whether that is they're having difficult conversations, challenging normative practice in order to create more inclusive environments. This project, this research, though in particular, was very different in the sense that the original ethos of the original approach of this project, of this research project, had been a sort of narrative that there was a belief that the Somali population in Hammersmith and Fulham was at a lower percentage of immunizing children in comparison to the rest of the population group in the borough. And one of the earlier responses back from me was that, well, unless this is based on evidence, that we have concrete evidence, this is not a statement that we're running with that bedrocks our research, but rather we flip it and look at it as an exploratory research endeavor to look at perceptions of childhood immunizations and the potential COVID-19 immunization, because they kind of fit right well in together, amongst the Somali population in Hammersmith and Fulham. And in flipping that, there was one, the removal of assumptions, but also work being done to be able to create space so that naturally other concerns can be raised as well. One of the added benefits of doing it through this approach was that we were able to create a means of challenging and engaging sort of these fixed barriers of conversation that seem to have been embedded. So the work was done with 3 community-based organizations through means of focus groups to, one, raise questions, the mention of childhood immunizations and concerns about childhood immunizations. And so participants were asked 3 questions on childhood immunizations. And there was a growing, while everybody had said that they immunized their child, it was a great natural space to be able to have conversations about where concerns, if they existed. And one of them was about the MMR vaccine and about potential developmental delays, learning disabilities, rather than autism specifically, which was another assumption that was made. But participants reported that there was sort of experiences that they received unclear information from healthcare professionals regarding the immunization process, and that this possibly, and the possibility of negative immunization, the negative impacts of immunization that resulted in their senses of heightened fear. This idea of, well, I didn't have enough time to ask these questions. And so there was this reliance on community members to squash any fears or concern that they had ahead of immunizing their children. But similarly, a sort of practice began to emerge and naturally exist and emerging across communities, relying on people that you have faith and trust with, of gaining information and it's not just practical information, but also gaining sort of advice in terms of what to do. And similarly, and so what that did highlight, was that there was a clear sense of general practice being as alternative, this other space that individuals felt they needed to go to, rather than feeling part of an inclusive member of it, if that makes any sense. This idea that we have to visit, we have to be invited, we have to have the space to be invited, not necessarily to the practice itself, but be able to be invited to feel that our concerns will be heard in a way that is validated, but also is presented with a time to have a sufficient answer to, and that the 10-minute appointments, lesser appointments, were not sufficient enough to be able to do so. On the other side, the concerns of the COVID-19 immunization were that the distrust, and this was early on, and so it's very out of date at this point because this was done back in the summer of 2020. The distrust from the majority of participants was that really like any COVID-19 immunization program that was to exist was that one, this was going to be something that was tested on Black and brown bodies first and foremost, and this was echoed by referencing the French researchers earlier on the pandemic, but also Tuskegee experience this idea of like, nope, this is going to be something that they test on our bodies to see whether it works or not. There was a lack of trust in healthcare systems related to sort of like that. As I mentioned, that historical perspective of testing on the historical experience of the testing on Black and brown bodies, and but more importantly, like the sort of misinformation about the COVID-19 vaccines that proliferated across WhatsApp. And this is, and this wasn't even just like videos or text, but included the use of like audio notes from members of groups to one another in terms of rumors of vaccinating children in schools, those who'd received a miscommunication or misunderstandings of letters that parents received about the HPV vaccination that were then mixed up with understanding of the COVID vaccination. Letters that were not translated into Somali led to additional confusion as well about COVID vaccinations in school, but also COVID testing in schools as well, and conflation of the two. And all of this rooted into this sense of, well, because I don't have someone specifically to ask, or because there wasn't a sense of feeling included into these spaces, we don't have trust in the new information that's being presented outward from us, towards us, sorry. And so in the workshop, there was quite a lot of brainstorming of ideas of how to improve not just the current immunization service, but at that point, the potential COVID-19 practices as well. And so to tackle concerns raised about immunization, it was agreed that sort of coordination of written information would be translated at all costs and at all times to a language, so Somali, that was digestible by communities, but also as well creating spaces where individuals are able to have conversations with clinicians from their community in an open forum type place that allows them to be able to express their concerns. And participants had reported that they feel that clinicians don't have enough time to discuss not just immunizations, but wider concerns with them enough in a way that is in-depth enough to dispel rumors. So dedicated sessions with these opportunities to ask questions would help address this. And I can tell you, like, even updates right now, like these are being done by community organizations like Mother and Child Welfare Organization, who are part of this focus group, where local clinicians are invited, and it just becomes an open question, like, let's just ask. And participants at the end feel, and members of the community feel more empowered, as they've reported, to be able to, one, create and take on action that's necessary or required across their community, including COVID-19 vaccine discussions and dispelling misinformation that comes across them across social media, and having these one-to-one conversations with family members, but more so being able to formulate and fortify trust with primary care in a way that it doesn't feel like it's a place that I go as a transactional relationship. I just go and I get cured or get my meds or whatever it is, and it's a short period of time, but rather a space that is seen as an embedded element of the wider community. This notion of sort of like creating trust at the center of action echoes a lot of the work that's being done across communities, not just here in Hammersmith and Fulham, but nationally. That at the end of the day, if there isn't trust from all stakeholders, and not this idea of co-opting community members into change, then change won't be, not one, change probably won't happen in a sustained manner, but also the change that does happen without this will be very fracturing for the wider community formation and sustainability in terms of the wider system approach. And so this got me thinking, and has me thinking quite a bit about flipping the script and utilizing forms of asset-based community development and entrenching within that healthcare system. And that's commonly done, or not necessarily commonly, but widely known across many areas. But so for those who've come across this for the first time, so asset-based community development is a type of community development that challenges sort of the deficit-based approaches towards across communities, to focusing on the assets that individuals, whether it's like physical property or people skills or knowledge skills, the strength in order to create, embed and engage with transformation processes. And it's a great holistic approach that enhances individuals' total health and well-being. The framing of health and well-being, in the sense that it flips the script on traditional models of asking questions and offering different lenses of understanding, the way in which asset-based approach, the asset-based community development or asset-based approaches as a whole, right, is that one, it focuses on the willingness of communities to be able to drive transformation and to drive change, utilizing this sense of power balance. And so like valuing the sense that community activists can sit in the same like proverbial table as a senior commissioner and be valued in that sense, and the asks that they bring are valued in that similar regard. There's strong evidence of the value of health assets and growing interest on how to like protect and promote and sustain them in order to benefit individuals and neighborhoods and wider communities. But it's challenging to sort of embed this in a systematic way across system, and it's been proven to be successful in like small pockets of areas. But what challenges are about whether or not environment is welcoming to this, if contexts allow for this, is and who's going to maintain this, or who's going to retain this. And it's a framing of like the community in this sense is a wider scope. And so how do we ensure that even when we are framing as an asset-based community initiative, that the community who is involved are also quite aware of the power imbalances that exist within them. But there are some like principal challenges of this approach in any case. And one focuses on the idea that, while the idea of asset-based approaches have been around for some time now, like a half century, I believe, the fact that people are only learning about it just now, or learning about it as a whole, makes it quite difficult for ideas to connect with wider practice in health and care services. And so you'll have pockets of practice, but it's quite fragmented from the approach of the wider system as a whole. Others, for example, believe that its approach in sort of breadth driven, so like the wider engagement across all, including all members of the community in creating transformation, which may or may not be right, makes it quite difficult to be able to hone in and have that depth element to change and transformation. With all that said, I'm not advocating it's either like a either or sort of assets versus deficits approach to improving health and health and well-being and services and outcomes, but sort of like this asset-based approaches, elements and services are really intended to reduce health inequalities and health inequities fundamentally by meeting the needs of the community, by the community, in whatever way the community is being defined. If it's complemented by sort of effective service design, it has a way of being able to meet in a sustainable way the outcomes, the the health outcomes that are beneficial for society, whether it's physical or mental recovery or management in any cost. But this does fundamentally require a sort of cultural change in practice, this divulging of power, and sorry, the relinquishing of power is what I meant to say, while simultaneously fortification and value added, like putting money where our mouth is, or no, putting money where we value, in change. So empowering and equipping community organizations with the assets and the resources to be able to amplify their assets and action the assets that they possess. And yeah, so it's a matter of including both, really. It's the main challenge is to sort of address the sort of, the main challenge is going to be about whether or not opportunities exist in the wider setting for asset-based approaches to be valued. And fundamentally emphasizing that element of who is responsible for addressing health inequities. And it's truly as a system, like as I mentioned before, there's elements of who's responsible for the mitigation, who's responsible for the prevention, and who's responsible for the undoing. But ensuring that all members within the community or wider community across the system are equipped with the resources in order to be able to do so, whether that is through upskilling primary care staff members, entrenching health inequities as a training in primary care in a way that's mandatory, widening the scope of practice, ensuring that work done engages with all elements of society. Sorry, that's my doorbell. And so how does this work in everyday practice? We see the way in which policies are frames in programs of design. So how can we frame issues like COVID-19, for example? We need to be able to have an understanding of the language used to identify communities. We need to be able to have a critical analysis of the policies that perhaps conflict with one another. Are we saying one thing and doing something else? And so some practical everyday tips. One is, in order to address health inequity goals and entrench trust, requires partnership with community groups, public health, and local leaders. This fundamental element of transdisciplinary action in everything that we do. Improving individual and population health requires partnerships. That's without a doubt. And it requires a sort of sectoral, transdisciplinary engagement, and moving away from an exclusive medicalized model of care towards a wider sort of clinical community relationship that creates multi-stakeholder collaborative initiatives that are far-reaching. So this includes focusing on daycares, focusing on green spaces, focusing on education, food banks, all of this in a way that looks at the holistic image of society, of the community. There is creating just the breathing space for clinicians and their experiences and their research to advocate for social change, being able to feed back to a system when something isn't working. And there are many clinical directors, many clinicians, the whole, and members of the wider primary care system who have done so, but it's coming across a sort of challenging wall of going against the sort of status quo, and how do we create those transformations? And I think this is advice for really everybody, is get involved in community needs assessments and health plannings, get involved in sort of the opportunities that allow you to integrate public health practice with primary care services, but also with the introductions of integrated care systems, actively finding opportunity spaces where community-based organizations and community members as a whole are able to advocate for themselves and are able to utilize, and those in primary care who are embedded within these spaces and in positions of privilege and power are able to amplify the concerns of the community as well. At a wider level, it's looking at it's intervening at both the sort of downstream and upstream determinants of health inequity, and action that focuses on individual behavioral determinants may inadvertently increase health inequalities in the absence of sort of like accompanying upstream socioeconomic, political, environmental, and cultural factors. Is that we risk perpetuating stereotypes or pushing practice that is underlined by these stereotypes if we don't look at it from a holistic perspective. And lastly, and I think most importantly, is the sort of monitoring and evaluation of interventions in its own right, but with full respect that in order to improve population health and health inequities, there needs to be current, appropriate, systemic, and to be fair, generally robust evidence to inform practice. It's not to say that the practice done is going to be universal in all sense, or even the research approaches or the monitoring evaluation processes are set in any regards, but it's key to ensure that we are mindful of what it is that we're looking to measure and focusing on that rather than the sort of general approach of, well, you see funding for X, did it achieve Y? And I guess this feeds into the way in which just funding opportunities are also available as well to be able to create these innovative transformation processes. So I'm not sure if there are any questions, but thank you very much again for taking the time to listen to me and to hear this. Again, this is, I think, the conversations of trust and health inequities and how they fit in together, something that is often not discussed as frequently as it should, but something that I'm sure those who are watching are equally passionate about as well. And it is a sense of standing firm to your beliefs, but also taking the opportunities to connect with others and best practice that's being done, but also utilizing, if you are in positions of power, of privilege, of influence at the system level, creating spaces to be able to do so. How can funding be used in a way that is valuable, impactful for the wider community rather than being a tick box activity? How can we create spaces to equip frontline staff with the knowledge, the resources, and the space to be able to do so as well? Thank you.
Thank you. Thank you very much. I'm just trying to get my video back on. Now, Mandekh, I realise that we're quite close neighbours. I should have said earlier, but I'm also an officer at the Royal College of GPs. So although my work is in the east of England, and that's my GP base and academic base, I am currently an officer at RCGP, Royal College of GPs, guys. Hi. And so everything you've said rings big bells for me. And I just wanted to appreciate the way you painted the picture of the challenge for general practice. Because as you're saying, most people go into, whether they go into medicine in the hospital setting or nursing, whatever health discipline, and wherever you do it, you go in to want to help people. And I chose to be a GP after I went volunteering in Africa and realized that, like, people were getting sick in Africa in a way that they weren't in my country because the NHS was giving early prevention and mother and child care. And, you know, and I wanted to be a GP because I wanted to get upstream of why people ended up being really sick. But having done 40 years in general practice, I'm not upstream enough in the current system. Because, as you say, however much I do my job and do the QOF opportunities to check people's blood pressure and try and prevent heart disease and help them to stop smoking and so on. But still, a lot of those causes are further back. So I did just want to say for colleagues, the Royal College of GPs has a current statement on health inequalities and is very aware, done a lot of the work with Marmot, very aware of the inadequacies in the system, and is really looking closely in all 4 countries at how to address the inequalities, also between practices, as you said, because some guys are working much harder with less income and less workforce in areas of real need. And the way the finance travels, through no fault of their own, doesn't always help that. So there's lots to do at the macro level, at the sort of advocacy political level. But stabilizing the NHS and making sure the public health function really does work, and the social prescribing model and the community health, all those, sort of making sure we can engage in that, I think is really important. And all around the world, my colleagues in primary care are saying, COVID isn't going to help us. Whatever the faults of our governments and our funding and our resource opportunities before, the will for change that you've so beautifully shown us with the Somali project is as just one very wonderful example. If we haven't got the space, the motivation and the resources, it's going to be really, change is going to be difficult. And the aftermath of COVID, when it is over, and it isn't over yet, is huge on everybody. So I just wanted to really say that GPs in my country are trying to confront this and stand up for this. But everything that Mandekh has said about needing to reach out and beyond and restructure the way that we can support and facilitate people in the different communities whose needs are greatest really, really matters. So thank you very much.
Thank you. Thank you so much, Amanda. I'm so happy to hear from you. I also want to say, when you said RCGP, I was like, this is a great time to plug it in. The Deep End group, which I'm a part of here in London. So Hammersmith and Fulham is one of the
exactly.
pilots. Is essentially a collaborative of not just GPs anymore here in London, but includes nurses and allied health professionals and community-based organizations in addressing health inequalities at a local level. And so it's a great opportunity for to have these topical sessions every week, different workshops, to be able to have these discussions of how does mental health play into this? How do we frame food insecurity into health inequities? But also being able to create those relationships, which is key, because that space is not often available in a formal setting. And these sort of structured opportunities allow them to be able to formulate these informal relationships. And Emmanuel.
Thank you so much for just a wonderful presentation that touches on the politics, the technicalities, the cultural issues that are so important, but ultimately social justice issues. I mean, this is what you're framing writ large. I was just wondering, given your provenance from North America, or at least partially from North America, if you could help us kind of walk us through some transnational learnings, whether that's from, Somali community in Minnesota and the US, or here in Toronto and Ottawa. There are lots of active groups that are concerned, even in a setting like Canada, like as in Britain, where you do have primary healthcare access, and then of course the much differing situation in the US. But what is potentially transportable in what you've studied, do you think, and what is kind of highly localized, contextualized in terms of these issues? Thank you.
Thank you. So I believe that the role of integrated workforce is something that is of value. I think one thing that I found as a big shock when I moved to the UK was the role of practice nurses in primary care. I was very much used to just seeing my family doctor, and that was it. That was my entire relationship. And so the utilization of multi-professional workforce through their professional experiences and training are able to have access to additional knowledge and resources and framing it in that sense, but also creating these opportunities for organizations like participatory study, smaller based, community-based organizations locally. So I know in Scarborough, for example, there are small local charities that are focused on knife crime and youth crime, and framing that, and how do we have those conversations, not just with the family doctors who are then able to proactively have conversations with young men who feel isolated by society or being isolated by formal systems, and being able to utilize that as a triggering process to not necessarily reroute them to institutionalized spaces that they would be hesitant to, but culturally appropriate resources that then allows individuals to be able to engage in a relationship, in a process that is conducive to them, but also allows them to be able to sort of unpack the traumas that they have. And so Hidayah House is one organization that actively works to promote this, and they're based in Scarborough. Oh, that answered it. It's a lot in the chat too. Ash.
Hello.
Hey.
What's up? Really appreciate the presentation. Really fascinating. Really admired your passion. It was really interesting to listen to. I don't know too much about health, so it was really nice seeing the context of like Northwest London, I think it was specifically.
Yeah.
And so being from out of London, I feel like some of the issues are quite similar as well. So I feel like if you had the funds to do a bigger study, I'm sure that a lot of these issues would be quite common across the UK. So I had quite a few questions. Feel free to answer whichever you want. You don't need to answer all of them.
Yeah.
Okay, cool. So for my first question was, where is it? So it was, what leads people in health management to make absolute statements? And this is in reference to your Somali community context, which was they went in, made an absolute statement, and then you guys changed your approach to an exploration one, like exploring.
Yeah.
And I just wanted to know what in the management led to an absolute statement.
Oh, this is I can say personal opinion versus I don't really know I don't know what's going on in their heads, to be honest.
Well, whatever you're comfortable with.
Yeah. I feel that across, and I'm not just saying this from a clinician for clinicians, whether it's GPs or nurses or clinical leads in general practice, but also for those who are in commissioning. So I was a commissioner, which is like the procurement of services and resources, for years after leaving the homeless healthcare sphere. That the sort of power that comes with that and the sort of authority that comes with that often allows for this sort of like ability to make these statements, but part of it is based on experience. And so if, for example, so in this case, this individual had only seen, the only people that she had seen who were raising questions or concerns regarding the vaccination were the Somali community. But she's able to, but the challenge that I had was, so you're taking that one experience and saying that, yes, it's a universal thing across the borough when you work in one specific area of the borough. And that makes a really risky statement, because now we're taking people from one end of Hammersmith and Fulham and another end of Hammersmith and Fulham and saying you are universal, but there's socioeconomic differences across just groups of people within one. So imagine, I don't know, like Luton, or for everybody, for people in Canada, Scarborough. If you imagine like where UTSC is, and you imagine where, I don't know, Victoria Park Station is, like two very different spaces. And to be able to say that there's a universal statement about a large population group is, I think, dangerous. But I can appreciate that we're framing this in the way of like, this is the knowledge that she possesses, but also being at a senior role, you're able to just say that.
I really appreciate that. I think Mary had a question next, so after mine. So it's in the chat.
Okay. Do you think that the adoption of physicians associated with the UK will make a difference to the levels of HR? Amanda, I think, answered as well. I think PAs will meet some of the challenges. Yeah, I think there is this sense, and Amanda, I'll let you jump in as well. There are a lot of new roles coming in. We've got physicians associates, we've got paramedics, community pharmacists, clinical, like all of these new roles entering general practice, which is beautiful in the sense that we now have opportunities to reduce the pressures that like GPs themselves are facing, that nurses are facing, because we have a shortage of nurses, particularly where I work as well, in terms of retaining them, to be able to ensure that the right person sees the right person at the right time at the right place is really the motto that I'm going to work with right now. And so creating these relationships allows us to be able to space this out, but I think we will still see that similar challenge in the sense that developing meaningful relationships isn't necessarily tied to what you like what your professional title is, but about whether or not you're given the space to be able to do so. Amanda.
Thank you.
Yeah, I mean, I put a very simple comment to Mary's challenge in the chat, because I think it all depends. You can add people into a system, but it's a question of what they're trained to do, what they're then asked to do, and you know, the space and the time and the encouragement and the support they have to do it. And so if the physician assistants are just kind of running around taking people's blood pressures and taking their bloods and helping with the home visits, they're going to basically be doing bits of the jobs that we're already doing. And if they are somewhere, and I haven't heard about this for physician associates, I have to say, it's more in the social prescriber and community health link worker models, you know, but if nobody's doing that role, it's not going to happen, is it? And we've been talking, you know, the need to have somebody who, in a sense, maybe is quite a senior leader in a practice, who is given the time and space, like the medical directors for the primary care networks are, who do the public health liaison and help with the outreach and talk with the community leaders. And there are good models of this, as Mandekh said, Bromley by Bow traditionally, but many others of the deep end practices who are working at the outreach with maybe one physician and then one healthcare worker or link worker, kind of completely different qualification, completely different person, but still colleagues together, getting out in the community and chatting to people and saying, hey, do you know the new vaccine? Actually, and then they're coming back to me. We've seen this in Brazil, actually. The Brazilians, although their health system's in trouble, they had a really good model of having community link workers going into the clinics, talking with people, and also bringing the messages back. You know, this is what the faith leaders are worried about. This is what the gangs are saying, blah, blah, blah. So I think if we don't invest in that, whether it's physician associates or any other category of worker, it ain't gonna run.
Yeah, and also to add this like sprinkle of like, I don't know, controversy to all of this, there's been a cut in the educational provisioning that is available to workforce staff by training hubs. So training hubs are traditionally the spaces that provide, once people are in work, training opportunities, whether that is like specialized training for nurses to do diabetes care, anything like that. And so cuts to that. And that usually was, for many boroughs, at least the ones that I work with in London, the space where they had the flexibility to say, well, we'll run a workshop on this topical issue, or we'll run a workshop on, I don't know, like health inequalities through this other organization, or employ somebody, or pay for the time of somebody within the local community to be able to have and facilitate these conversations. And so part of the challenge is, how do you equip individuals who are working under pressure, who then may risk limitations in additional resources?
Yeah. I can see other people want to come in, Maggie, but just one other comment is, we haven't talked so much about the role of formal training. And again, that's very culturally and ideologically specific, isn't it? If you do a lot of very, you know, disease-oriented training and you expect to go into a private practice when you finish, that's one thing. And if you have a lot of placements that are really enabling and empowering and help you as a young doctor to get over the fact that you didn't know people lived like this, and actually come to be interested and value that and want to work with those communities, and be in a deep end practice, then you're transforming the health system. So the role of medical schools, nursing schools, pharmacy, whatever, that needs to change as well if we're going to really enable people to pursue their profession in a broader context, I think.
Thank you. Maggie.
Thanks, Mandekh. I was curious about, I'm not so familiar with the Somali community, but you mentioned FGM, and I'm curious, I guess, about whether the biomedical or dominant health systems are trying to connect with, when you talk about culturally relevant sources of health understanding, is there an active intent to understand these different communities' perceptions of health and, like, you know, specialize, I guess, the communications and outreach?
Yeah, no, I think that's definitely being done by many.
Mm-hmm.
I think that's definitely being attempted by many and being embedded by many, particularly those in the deep end, which is the practices that are in the most socioeconomically deprived areas of the UK and like patches of it. I think that's being done, but that part of that requires a lot of not just self-motivation, but the ability to have that space to do so, to be able to engage with community groups, to be able to facilitate those times. But we need to take into consideration for clinicians who are not partners, who might be only working a couple of hours contract. That's quite challenging for many. For those who don't necessarily have job security, that's challenging for many. I think part of it is like, how do you get a foot in a way that is sustainable, with a concern that if we have, in some areas of London, we have such a high turnover rate. And so how do we ensure that those relationships are embedded in something that's meaningful? But I think that this idea of like seeking out knowledge does happen. And so I work with one GP who isn't a part of our deep end scheme, but he's like in every one of the workshops. Like if I need him to be like, I need a GP to speak on this topic, or like you're having additional questions, he's like down on it. Like, I'm ready to do this. And he borders one of the community, the estates. So like Metro housing equivalent in Toronto. Mm. And so he like values that sense of like, I want to be accessible. I want to be accessible, but still be able to have those like professional boundaries where individuals know that like, I'm here for X, Y, and Z reason, but I'm not able to, for example, write signed letters that they would have traditionally been able to do. And practices are able to make these decisions themselves. Mm. I answered in a really roundabout way.
Yeah, I think I'm just wondering, especially given, I don't know the London context, but given skepticism around vaccines, different kinds of, I forget the term, but like non-Western medical perceptions. I'm just curious if there's been any form of integration, like, for example, in India, there's Ayurveda, there's Chinese medicine. How much of those understandings of health, holistic health, is being integrated into these programs? Because I'm imagining that these cultural communities are much more familiar with these kinds of health systems. And to me, that seems like an important disconnect.
Yeah. I'm going to say from the ones that I know, I've personally never had those conversations. They might come up in other practice settings. I know, like I remember having one conversation with a GP about, I don't know what the English word for it is. Like, it must exist. Like it's Dinsi. It's like this like herb. It's like antibiotic herb that Somalis and like East Africa, like I think Ethiopians also use as well. And I genuinely can't explain the English equivalent of it, but it was like, it cures like particular like aches and pains and things like that. And somebody was like, well, no, I'm not going to go to the GP to get X, Y, and Z prescription. I'm just going to have Dinsi. And the other member of that like focus group was saying like, no, you should still go. And it became this like fundamental clash of, I'm going to I don't want this, I am going to do this. And whether or not this permeates in conversation general practice, I'm on a regular basis, I'm not sure. But I think there's definitely this sense of, as I mentioned, like the structure of operation that still exists.
Thank you. I think Ash had a question, and some folks that have been wanting to say bye in the chat. So for people who need to go, thank you.
Okay, cool. I got a few questions. Hopefully, they're not too hard. So I got 3 questions, 4 technically. So have you tried? So right, because you spoke about systems quite a lot, and I thought, and there was a lot of questions thrown out like we need to think about this and we need to think about that. So I was like, I decided to think about it, right? So then that led me to ask these questions, which is, have you tried to bring relevant people together to try draw a systems diagram? And do these people have the tools to see systems? Because a lot of people, because you got systems in healthcare and you got systems in engineering, but people may actually observe systems differently and actually, they may see different things. So that's my question. Oh, that's the first question. The second question is, sorry, I'll just read out all of them, then I can just shut up. The second question is, do lines of communications already exist to bring organizational change? And the third question is, how can we help people see solutions when resources are limited in the current climate of the UK?
Okay, so I will answer all 3 of them fairly briefly. Have I tried to bring relevant people together to draw a systems diagram? Trying to bring people together, period, has always proven to be a fundamental challenge. And bringing people together in a way that they value each other's opinions. So not even getting to the point of designing anything, but fundamentally being able to say that a community-based organization leader and the head of workforce development for all of Northwest London, theoretically, I'm going to put asterisks because that's not really the job title, like bringing all of these people together, commissioners and senior clinicians, and valuing those within the community or those who have stakes within the community together has always proven to be difficult. There are platforms that facilitate this in the integrated care network systems, but it's still a challenge to genuinely do this in a way that the voices of those who are not clinicians, those who are not senior positions, and those who are not at a pay grade that's like wildly above everybody else are able to feel that they can actively engage, like honestly. Do the lines of communication already exist to bring organizational change? To some degree, they do exist. I think the issue is the listening, and the listening in a way that takes into reality and reflections the experiences of what's happening on the ground. Because I think there's often times where like decisions are being made at the meta level that make sense numerically or on the like, data level, but on a practical level, practices are under pressure. Like some of them are single-handed, so there's one GP that runs most of the places. There's a bubble that's emerging in many areas of retirement and none being unable to fill it. Those who are leaving primary care fundamentally because they're not receiving adequate pay or feeling that they're not receiving adequate pay and would go to a place that offers them better pay, like private, or even moving from borough to borough, one area of London to the other. Like I know one area where like literally if you move across one border, you were guaranteed $5,000 more as a nurse than if you were on the other side. So the lines of communications exist, but it's an active listening that I think is frequently missing. And how can you help people to see solutions when resources are limited in the current climate for the UK? So in my role is in workforce development, more particularly for primary care staff. I am a big advocate of flexible funding. Just as a side note, I believe unrestricted funding will allow us to be able to have these opportunities for innovative change. And sometimes money comes down as like, you must do it for, I don't know, GP retention and recruitment. I'm like, that's nice. But then you've given me like 4 categories of work that I can only do. And I don't really want to do any of these. I think that a better use of the funding would be if we refocus some of it on how do we have conducive conversations with a community like community X or organization Y in our local community. How do we foster this like one of the projects that I wanted to run was a parity of esteem, project, which was looking at the parity between mental health and physical health, and like making this into a game, not just for primary care staff, but including law enforcement staff who were utilizing arresting people as a means of getting them sectioned, and including social welfare services, including the community-based organizations, so we can have a wider discussion of the experiences of mental health and physical health well-being of homeless persons in a particular borough of London. So that kind of flexibility allows us to be creative. And I think that's a challenge if you don't have the resources available for you to do that. Sometimes it's just being creative.
I appreciate that. I appreciate your answer. Like, no, I'm definitely the answer to bringing people together, especially when they don't have interest in each other and they have a lot of ego. It's definitely difficult. I remember once I was doing some community work with an organization in my town, and one of them was just like, "We don't go to people. People come to us." And I'm like, that is so fascinating. Makes a lot of sense. And then I just carried on doing my work. But yeah, I appreciate it. Thank you.
Thank you.
So we are gonna formally end at about the 30, but if anyone has any last questions, now is your chance. Or Mandekh, if you'd like to have any closing thoughts to those who are still here.
I really appreciate you all for sticking out, follow us and with me. I'm really nervous all of a sudden now, but I genuinely appreciate you taking the time to listen to this. This is, as my colleagues know, like an issue I've always, like this area of access and health and justice is something I'm particularly passionate about, and something that, to be fair, maybe 6 years ago, I wouldn't have thought was a specific focus of mine, but on reflection, that's literally what I did in my dissertation. And so it's interesting how life comes at you this way. So I appreciate it, and it's great to connect with all of you, and I hope to speak with all of you soon. I mean, also UK people who are here in Jerusalem. Thank you.